Thank you. So thank you very much. I'm glad to be here, and I'd like to express my thanks to Valerie for putting all this together. I've reached a stage in my life where my glasses don't focus at any length anymore, so I have a choice between reading my notes here or staring in an unfocused way out at the audience, so bear with me also. Sometimes I mumble, sometimes I shout, so we'll see. And so the purpose of this talk is to go over Do Bugs Need Drugs, which, as it says here, is a community program for the wise use of antibiotics. And this is basically just a discussion of who we are, what we do, and also how, if you want, you can work with us at various stages of commitment. I mean, sort of the background for this is that all of us work in AMR or are interested in it. And our programs or efforts exist in a framework where there is no real coordinating body. We have a national plan, but we don't have a national funder. You know, we have national organizations that want to work in the area, but sort of lack the institutional setup of the provinces. And so you get events like this where everyone here is agreed on what we want to do, but we also all have to work independently and answer to our respective provinces. So what this is the reason it's called a community program for wise use of antibiotics is it focuses on antibiotic prescribing in the community, but it also, it also has the effect of trying to use the community as a resource to affect antibiotic prescribing. And the way in which it does that is one of the things I'll be getting into. I myself have a background in anthropology, and after teaching in human biology for several years, I became tired of trying to educate people and switched to public health as a way of escaping from that duty. And so one of the features of being an anthropologist is often you're speaking to groups of people who have a very different background than you do. And so if anyone has any questions at any point, you can just shout them out or raise your hand or anything like that. And I just wanted to comment on two aspects of AMR. One is that it's a mass action program, a problem, sort of like global warming, where every person who contributes to the problem is frequently contributing to it for actually good reasons. They feel that their contribution is either tiny or doesn't exist at all and will produce a small individual benefit, whereas all of the problems in aggregate are become a real problem. And then the second thing to consider about it is that it's in some way a tragedy of the commons, where a resource that used to be held in common starts to get used up. And in this case, the resource is bacteria that respond to antimicrobials, and part of the privileges that are being lost are the privilege of every individual to behave as if antimicrobials are unlimited. And so in a tragedy of the commons, for example, the collapse of the cod fishery in Newfoundland, what you have is new regulations and new structures being imposed on an old structure, which causes difficulty for everyone who had set up a system to exploit it. And I was struck particularly yesterday in the fourth presentation by someone working in veterinary medicine of how poorly the new regulations about antibiotic purchasing are going to work for producers. And I was just struck that this is what happens when a commons starts to be depleted. You have people who have been using it and depend upon it and are now losing their ability to access it in the same way. And there's no particularly good solution to it, but it's just worth, I believe, remembering that in those situations, no one's actually at fault. They're trying to adapt to changing circumstances. Yes? Yes, I do somewhere. Yeah. Yeah, and so I just felt like saying that. It's the perspective that we approach it with, just not as entirely a technical problem that's being caused by either doctors or patients or pharmaceutical developments, but just what happens when everyone uses a resource until it starts to vanish. And so, okay. Sorry, I thought I had a different map up there. Anyway, sorry. So the second purpose of this talk, though, is to introduce people to Do Bugs Need Drugs as resources and describe the program so that you can work with us, if possible, with a minimum amount of friction. And so what we have really is, in my updated map, Saskatchewan was on this as well. I put them on as a partner. Here by virtue of organizing this conference. But we have two formal programs in Alberta and British Columbia, based in Edmonton and Vancouver, respectively. The Yukon and the Northwest Territories are both limited partners in the sense that they have access to bugs and drugs, which is related. In Manitoba, we have the South Health Regional Health Authority. Can you raise your hand? Who's begun using some of our materials and is exploring ways of working with us. And in the far east, we have the Network of Atlantic Antimicrobial Stewards. Are there people here from there? Yes, yes. Yeah, and they're not technically partners in any sense, but I think of these groups as fellow travelers, people who are considering using our resources, have aims and similar, and collaborate to the extent that we don't want to be reproducing the wheel. And then finally, we have PHAC and the NCCID. Harp is over there, and Denise is there, and both of whom are playing a valuable role as national coordinating supporters. So I see this is my older, okay. So this is Do Bugs Need Drugs as it exists today. And I'm going over all of this not out of egotism or pride, but because these actually control to some degree what we do. They represent both sources of cooperation and friction between Alberta and BC. And they are also things that anyone who wishes to partner with us somewhat formally would have to know. So we have two institutional homes, AHS and the BC CDC. And the two programs are actually completely separate. I'm speaking here today on behalf of the BC CDC as well, but that's only in the most informal of senses. The BC CDC may not be aware of that or approve of it if they were. We have obviously two provincial governments with two sets of goals. And then there's a technically unaffiliated prescribing app called Bugs and Drugs, which is frequently confused with our program and vice versa. It's owned by AHS. It's made available elsewhere for a nominal fee. And both Bugs and Drugs and Do Bugs Need Drugs were founded by the same person, Dr. Edith Blondell-Hill, and have the same, share many of the same experts who maintain them. So, and we support each other, but we are technically different. We each have our own advertising campaigns that are individual. We have one set of shared print resources that are housed in Alberta. There are two websites. We have about 1.5 logos and 3 graphic identities. And these are actually more serious issues than one would think, because the original Do Bugs Need Drugs began independently and was housed at a nonprofit, the Alberta Lung Association, for many years, which is when our website was created. Alberta Health Service programs normally don't have individual websites or logos. And so we joined AHS 4 years ago. Right now we are updating the logos and the websites, and this has had the effect of actually making AHS aware that we have these and creating certain levels of angst with them. We have a social media presence that's managed largely out of British Columbia. This is another bone of contention. AHS's communications department feels a certain amount of uncertainty at having their logo put on tweets coming out of Vancouver. 2 sets of staff, and 2 sets of unpaid expert advisors. And one thing that I would really like to emphasize is that I'm quite new to the program, actually. It's been around for about 20 years. And for 17 or 18 of those years, it was run by Mary Carson in Alberta, Kim Dreyer in Vancouver, who have both moved on. I'm sure there are people here who knew them both. And the materials and resources and expertise that I'm talking about were built up by them and by the cohort of people who have done a large amount of work for no pay whatsoever. And that last set actually is much of what's given the program the reputation that it has. So let's see, hold on, I have to advance this. Okay, so the program core is education of the public about antibiotic use, resistance, and conservation. And I'll discuss this and then get to how we actually hope that works. So we have 3 key messages: that hand washing is the best way to stop the spread of infections, that not all bugs are created equal. Both bacteria and viruses cause infections, but antibiotics only work against bacteria. And use antibiotics wisely to stop bacteria becoming resistant to antibiotics. And basically everything that we do supports these in some measure. Generally, we push 1 and 3 harder. Number 2 is slightly more abstract. As a former teacher, I would like people to understand it. I'm also pessimistic about the possibilities of ever achieving that in high numbers. The fact is, most people don't think about bacteria and viruses frequently enough to maintain the distinction between them. Let's see. Sorry, I keep forgetting that my computer. Okay, and so our areas of activity. We do public education, but as everyone here who's worked in public education or public health is aware of, the public is a fairly diffuse and large entity, and that there are ways of working with them that are more intensive and ways that are working with them that are fairly cheap and easy and difficult to evaluate and difficult to trust. Has anyone here ever had the experience of, say, sitting at a table in a mall as people walk by, giving them pamphlets of useful information? Yeah, it's after you do it, you lack trust that your pamphlets will be read or understood or even retained, so to speak. And as someone who's worked in a classroom before, even at the college level, you develop doubt as to the interest or even ability of people to learn. And so, no, I'm serious. yeah, I'm serious. I'll talk about that later. And so, like everyone in public health, we spend a lot of our time looking for existing organizations that can take our material and spread them for us, instead of trying to do it ourselves at limited levels. And so most of these things here represent in some way a clump of people who we think will be helpful to us to getting materials out. So for example, education for young children. We have a number of materials for early childhood education, and I'll go over some of the ways that we get them out. I'll just go over them right now. What you see right here is our grade 2 teaching kit, for example, which is a developed curriculum for people working specifically with grade 2, but which is adapted for anything in the different elementary schools. And we try to find nursing colleges that are willing to use this for their 3rd year community education outreach for student nurses, so that we give it to a professor, the professor gives it to their students, trains them on it, and then the students go and deliver classes on hand washing and proper use of antibiotics in schools. We have partners in Medicine Hat College, at the University of Lethbridge, and the Grand Prairie Regional College, where professors will take the developed curriculum and give it to their students to take out. And this activity, actually, we hope has 3 effects. Obviously, it teaches the children about hand washing, but secondarily, it should teach the student nurses about AMR and hand washing. And hopefully, we've chosen grade 2 because that's a very specific age where children are still young enough to be willing to talk to their parents about what they learned at school and old enough to understand slightly more complex messages. So if you do it older, the children no longer speak with their parents about, about what they've done. And if you do it younger, they don't understand it. They'll remember something like using the glow gel or something like that. Let's see now. We have an early childhood educator program for daycares and day homes, which we don't deliver actually to the daycares themselves, but we try to find opportunities to give them to larger organizations or work with larger groups of daycares and day homes. That's mostly on hand washing. Let's see here. Oh, I see how it works. Okay, those come up. Sorry. So the map on the left is the areas where we have buy-in from nursing colleges, and then the middle part is our early childhood educator. You can see the two different logos from the middle one there at the bottom, and then the new one that we're trying to develop and get permission for used on the thing. I should point out that because there are so many organizations here, the logo situation for a presentation like this is very complex. Sometimes we use DBND, sometimes I use Alberta Health Services, and I have a couple of slides that are largely from BC where I use the BC CDC logo. If a third province ever joins up, it'll become prohibitively complicated. And, okay, not yet. Yeah, so moving on. We have a program to try and work with long-term care facilities, a fairly detailed and complicated one. And it has two aspects. What you see here is the data collection aspect, where every quarter, out of the approximately 180, 190 long-term care facilities in Alberta, about 2/3 of them, 135, submit all of their data on antibiotic use. And then we break it down into UTI, RTI, skin and surface tissue infection, and unknown based upon what antibiotic it was. We don't have access to the actual diagnosis. We presume, based on expert opinion, what that antibiotic was prescribed for. And then we organize the data and put it up on the website in a semi-private, semi-anonymous form where it's ranked by number by facility code on the left, and then you can see the graph of how the antibiotic use breaks down every quarter. And then supporting this, we have a number of technical resources, prescribing flow charts for nursing home acquired pneumonia and UTIs, which are intended to support an evidence-based diagnosis for a prescribing environment where a nurse is monitoring symptoms or signs and then phoning them into a doctor who will prescribe something. And the aim is to, first of all, break the use of non-evidence-based diagnostic criteria for a UTI in particular, for example, cloudy urine or things like that, and base them on symptoms and not urine dipsticks. And then we also have resources because of the high turnover in staff in places like these. We have resources to support the training departments of long-term care facilities when they bring in new staff and want to train them on these issues or things like that. And the hope of this data is that people will use the materials that we provide and then look at this data as a form of feedback as to how things are going. It is not used in a regulatory or prescriptive way. It's very rare that we call up an institution and ask actually what's going on. And the main reason for that is we aren't regulators, and people submit this data voluntarily because they want to work with us. If we make nuisances of ourselves, that is possibly something that would change. For example, one of the times that we called up is when for some reason there were 47 prescriptions for rifampicin at a particular home. And we were wondering if they had a severe outbreak of multi-drug resistant tuberculosis or something that they were fighting with. And it turned out it was a coding error in the data or something like that. And that represents a very rare case. Now, that said, this is very hard to evaluate. It's very hard to evaluate whether an institution is using the data or not, or whether mindfulness translates into usefulness, so to speak. And so what we're thinking of doing now, we're trying to work on where this will go, and we're thinking of making it into something where we look at perhaps the top 5% of institutions and just going out and talking to them and seeing what are their structural practices. How do they set up training of new staff? How do they institutionalize best practices? And making up sort of an HR chart for that. This next slide is going to be our one of our programs for the general public, an outreach announcement.
Cough? Sniffles? Sore throat? Chances are you have a virus and don't need antibiotics. Bacteria become resistant to antibiotics over time. Use antibiotics wisely to help prevent this. Ask your doctor if antibiotics are actually necessary. Save them for when you really need them. Your body will thank you. Find out more at antibioticwise.ca.
So, you'll notice the graphic representation of selection, of the evolutionary selection there, which I'm sure was, never mind. Sorry, I used to teach evolutionary biology. Yeah, and so that advertisement sort of represents the limit of what we've done as far as trying to talk to the public. We feel constrained by the fact that we don't want to make people afraid of antibiotics. The problem is that they, unlike smoking or other hazards, antibiotics are a useful tool that has drawbacks. And so we don't want to use any type of fear about getting people to moderate their use. We've discussed, I'm sure everyone here who is on Facebook is aware of how the hygiene hypothesis has sort of infiltrated its way into modern consciousness. How many people have friends or associates who talk about gut fauna when discussing health or things like that? Yeah, gut fauna is the new cholesterol or something like that when it comes to something. And obviously antibiotics affect gut fauna, but at the same time, it's an area that is tremendously complex, just like diet, and it's hard to actually say anything conclusive about it. But we really don't want to make people worried about antibiotics. And our goal of all of our advertising is not actually reduced antibiotic use. If anyone in the audience is taking antibiotics, we are okay with that. Our hope, our actual ask for the antibiotics is that you talk with your doctor about it. And so at some level, the success of this approach depends on the willingness of doctors to cooperate in this sort of evidence-based thing. We have a number of translations. So we've translated our Guide to Wise Use of Antibiotics. This is our most complex resource. It's a 20-page pamphlet on common childhood illnesses intended to support parents when they talk to a medical provider. And so we've translated it into multiple languages, French and other languages of immigrants, Arabic, Spanish, Chinese, Vietnamese, Somali, Korean, Thai, Italian, Japanese, Punjabi, and Farsi. And one reason for this is immigrants form a clump. They're a discrete group of people who it's easier to reach. And one of the problems always with teaching is that the teacher has to have a certain level of standing with the person that they're teaching. And this can be really quite difficult to get. When you're, in my earlier example of when you're sitting at a table trying to educate people who are walking by on the way to Safeway, you have very little standing in that situation. You know, when you're educating people in a college class, even though they've paid for it, you would be actually surprised at the number of people who are actually totally uninterested in learning anything that they've actually bought. And one way to give yourself a certain level of standing is to show that you care about and are interested in the group of people who you're trying to reach. And for me, at least, the translations are one way of doing that. And practically, I think that they're useful because they reach groups of people who grew up in different medical environments and have different backgrounds in antibiotic use. Many people come from countries where antibiotic use is unregulated, is free, and is considered a hallmark of going to the doctor. You go to the doctor and you get antibiotics, or you buy them in a drugstore. And a lot of people also come from medical cultures where you're not expected to discuss or argue your treatment with a doctor. And so the purpose of these pamphlets is to give people some support in doing those things. These are occupational health pamphlets. They focus on hand washing. They're specialized resources for work camps and natural resource industries. We have other videos on our website as well. And this is one of the aspects of the program that was emphasized more in the past and a bit less now. To me, this is one of our more diffuse efforts. It's hard to measure the impact of handing out pamphlets on hand washing to the general population. Let's see. We do work with professional organizations towards optimized practice, Choosing Wisely Canada. And at the bottom is something that one of our recent efforts, this was done by David Patrick, the leader of the BC team, to provide support for dentists to prescribe antibiotics appropriately and in more limited fashion. These are important because as it was described to me when I came, you won't change doctors' practice through guidelines or evidence-based things, but you'll never do it without it. They're sort of the basis for beginning. Let's see here, is this on? Okay. And this is something that I put up. Please don't feel that you have to read this, but this is the formal logic model for the BC program. And so many of us work in institutional environments where you have to justify, the resources, the outputs, the outcomes, and the impacts that you'll do. This is one example of those. Alberta Health Services has never actually developed one of these. Ours is essentially identical to this, but we have never actually measured the impacts to the degree that British Columbia has. Let's see here. And so why do this? This is a quote from an editorial about 10 years ago. Rules and guidelines alone may not be sufficient to bring about effective and sustainable optimization of practice. Best practice needs to be positively reinforced by an environment that facilitates and supports optimal prescribing choices, i.e. a choice architecture that makes prudent antibiotic prescribing the path of least resistance. And I found yesterday the discussion of the Choosing Wisely campaign very interesting and very, very relevant in that it was discussing the degree to which doctors practice in an area where they're expected to be evidence-based, but that at the same time, much of what they do is driven by other concerns. The absurd example is the one where they start to prescribe more antibiotics the closer that you get to noon or quitting time. And with one explanation being that they're experiencing decision fatigue, where they've made so many decisions that they start to cut corners. Another possibility is that they're getting hungry or tired, and hungry and tired people have a tendency to choose the path of least resistance, so to speak. I was myself particularly actually kind of struck, though, by one point, and I forget the exact magnitude of it, but it said that doctors dramatically overestimate the demand for antibiotics from their patients. And that actually made me think, and this is a question for you guys, what kind of person becomes a doctor? Like, what are the motivations that make people want to become a doctor? They want to help people. Yeah, that's one. They want to help people. And what kind of person do you have to be? Many people want to help people. Like, I have no particular issue with helping people. I do it myself sometimes. But, but what kind of person do you have to be to become a doctor? Everyone here probably has intimate experience with doctors, but you have to be highly motivated to get yourself through the school. You have to be able to put off gratification for a long time. Not everyone will study for 7 or 10 or 12 years in very difficult circumstances to become what they want to be. What is medical residency like? Yeah, I heard that too. Yeah, I heard that too, and it like builds up your self-esteem and things like that, and yeah. Basically, to be a doctor, you have to be highly committed, you have to be dedicated, you have to be driven, and you have to want to help people. And then after you've done all of this, if you're a family doctor, you begin practicing, and you find, I don't know, say in a day, 50% of the people are families coming in with viral sicknesses. Possibly. Do you have days like that where one person after person after person comes in with a viral infection? And what do you do for them? You do nothing. You tell them the same thing that your parents told you when you were sick. You need to stay in bed, and you need to take a hot bath, and you need something warm, and you need to get a lot of rest. And these are highly educated, dedicated people who are trained to solve problems and have put themselves through a lot. And so they believe that these people want antibiotics from them. It's not a discreditable thing. You're believing that the people coming in want you to help them, and you have very little ability to do it. And that, I think, is what's so genius about the RX files, viral prescription. It gives you something that your hand can do that's formal and is somewhat more important than just simply telling them, I can't do anything for you. You have a cold. And much of what Do Bugs Need Drugs would like to do is produce materials that support an effective interaction between the doctor and the client, where the client is essentially supporting the doctor to do the right thing. And so we try and educate the public. It's the opposite approach. It's using the community to work with the medical prescriber instead of the medical prescriber to work with the community. And just as an example of how this can work, in the presentation on yesterday, I thought that poster for the medical office, antibiotics won't cure your cold, or something like that. That's a great poster, but it's not aimed at the public. It's aimed at the doctor. It's given to the doctor, saying, here is some material for the public. We want to help you. They're coming in and they're demanding antibiotics. We want to help you. Say no to them. But that's telling the doctor, stop prescribing antibiotics. And it's there every day on their wall. How many people here have children? How many people have ever experienced something like I experienced the other day when I went for a walk with my 4-year-old, and all of a sudden he shouts at me, Dad, you're jaywalking. Or so and I was like, yeah, I'm jaywalking. We're not supposed to jaywalk. And I go, well, no, I guess technically you're not supposed to jaywalk, but it's a residential street and there aren't any cars coming. And he's going, Dad, they told us at school not to jaywalk. And then you walk down the street with your kid walking behind you, nagging you. I don't understand. Why did you jaywalk when the teacher says that you can't jaywalk? And this is the same effect. You can use children or the public or patients to get at people who are technically in positions of knowledge or authority. Just like the school used my child to get at me. And then this is repeated with things like bike helmets and whatnot. Yeah. Anyway, yeah. So that's what we do. We try to change the environment. And another way of looking at it is we try to change the public. When you look at the amount of prescribing, you can change the behavior of the practitioners, or you can change the behavior of the public. And we will work on both if possible. Our desired goal really is wise use. From the public, we'd like acceptance of antibiotics, plus caution in using them, and plus verification. And verification is simply, when your doctor prescribes antibiotics, that you have the ability to say, if you're prescribing antibiotics, you must think that there's a chance that I have a bacterial infection. Why do you think that? For medical professionals, we want mindfulness and a clear decision ladder. From everyone, we want plain hand washing without fanaticism or using any kind of special antibacterial soap. And finally, by without fanaticism, what I mean is this. If you actually look at our regulations for our suggestions for hand washing, you can't really go through life following them all. And so this is the trick of educating the public, is that you need to give them advice that's useful but not it can never quite be comprehensive. And just educating anyone is a tricky process. It doesn't have a strong evidence base. When I was a teacher, there was one time when I got fed up, and I decided that semester I would put in more work and everyone in my class would get an A. So I tried to optimize everything I did. I had special sessions. I thought clearly about what I did. The grades turned out to be exactly the same as they always were. And I realized then that either I was a bad teacher or that it's really hard to educate anyone. We don't actually have a way to educate the public. If we did, there wouldn't be a controversy about vaccinations, for example. If there were, we could say, this year our influenza vaccine rate is going up by 5%. And we can say that, but it won't go up. And at some level, the only way to get people to change their behavior is to pay them or to make it worth their while. I'm not going to go into these in detail. This is work from David Patrick in British Columbia, showing how antibiotic prescribing has changed in his province since Do Bugs Need Drugs was begun at the Green Line in 2004. He has quite a bit of work on this. I don't want to go into it because he understands the technicalities and it's his work. But if any of you need evidence-based evidence to support this program, he has the best that there is. As with all public health programs, it can be quite tricky to evaluate. Sorry. And if any of you face funding constraints, he also has evidence that shows that the program saves money. As with all public health programs, that can always be argued. Let's see. And so working with us, there are a couple of things. Like, if you're interested in AMS, our materials are easy to use. You can order them. We charge a nominal rate, for shipping outside of Alberta or British Columbia. The basic conditions are that you don't do anything that goes against our 3 key messages, that you don't alter the materials, and that you give us credit if credit comes up. These are generally not difficult issues. If you want to be a formal partner, you have to informally accept the complex structure of existing interprovincial relationships and don't do anything that throws those into whack. A good example actually is One Health. Where I work, the Alberta government is quite sensitive to us saying anything about agriculture. The Ministry of Agriculture is very uninterested in having Do Bugs Need Drugs comment on antibiotic use in livestock of any sort, so we don't. One time we had a cow appear in one of our public advertisements that was simply intended to show that, we're common people of Alberta, farmers, people of the earth. And we got a call from the ministry, why is there a cow in your ad about antibiotics? And we were like, we didn't think about it. So, so yeah. But to do it really well, you need a champion. Okay. To do it well, you need a champion and people behind them. Unfortunately, I only have the British Columbia team here. The Alberta team didn't quite make it. But it's the opinion of Edith Edith, who started the program, and David, who they're third from the left in that program, in that picture in British Columbia, that that to actually do AMS public education in a province, you need a champion who can push it, and that one of the virtues of the program is that it has a team of experts who have supported it for a long time, and that it's more than simply pamphlets that are handed out, and that the people here, who I really regret aren't there, Edith and Susan Freiders in particular, would support expansion of the program. It'll always be independent. In a way, it's a misnomer to talk about there being a program, because British Columbia and we are actually totally separate programs. So that any additional Do Bugs Need Drugs would be a third provincial program or a fourth provincial program or something like that. But it really can be a source of strength in that each program can develop new materials. So for example, the dental material from BC that we'll be adapting hopefully into an Alberta context at some point. Okay, that's good. Okay, so thanks very much. And I have packets of materials back there if anyone wants to take some. And I invite anyone who's interested in using the materials or discussing bringing it into a new context to talk with me. Thank you very much.